And now we will have our second speaker, Dr. Chun-I from Taiwan. Dr. Li, our Dr. Li is online. Okay, great to have you today, Dr. Li. Now, allow me to introduce Dr. Li. He is the hospital CEO of Li Women's Hospital in Taiwan. Dr. Li has worked specifically with the infertile couples for over 5 years and is a prominent researcher, have published many studies on reproductive medicine. In his presentation, he will talk about the value of the endometrial receptivity and the endometrial microbiome for improved pregnancy rates in RIF patients. And a kind reminder, if any of today's audience has questions, please leave your question in the chatting space and we will collect the question for speakers. Thank you for your collaboration. So let's welcome Dr. Li for his presentation.
Thank you. Okay. Hello, good day, everyone. I'm Dr. Chun-I Li. I'm CEO of Li Women's Hospital. It's my honor to share our results on our study on endometrial testing. I'm going to give a talk with a personalized embryo transfer improving clinical pregnancy rate in infertile women with recurrent implantation failure by endometrial testing. I have no actual or potential conflict or interest in relation to this presentation. Fertility depends on a receptive state of the endometrium. The embryo is able to implant in a specific receptive period of time during a woman's cycle. This is called window of implantation. The implantation window is a short interval during the mid-secondary phase. When the endometrium is more receptive to blastocyst implantation, it begins on 20 to 24 of an ideal menstrual cycle and lasts less than 48 hours. Morphologically, the endometrium is one of the most dynamic target tissue in women. Its cyclic structural changes mirror changes in metabolic functions, and both are regulated by ovary estradiol and progesterone. There are different tissue morphology results from pathological HC stain in menstrual, proliferation, and secondary phase. In previous diagnosis of the different endometrial stage or implantation window was analysis by dating pathology biopsy, but detecting the morphology of the endometrial cells may be not more accuracy than molecular elements expression in implantation window. So illustration of key elements in blastocyst endometrial interaction need for a receptive endometrium. Due to its important contribution during early presentation, the endometrium is key to healthy pregnancy. During the window of opportunity, like we know the day 19 to 24 of the menstrual cycle, the endometrium resides in a receptive state that allows selection, apposition, and attachment of a healthy blastocyst. Implantation is marked by invasive growth and differentiation of trophoblast cells. Proper interaction of invading trophoblast and the local immunity is needed to achieve correct valid development and a healthy placenta. All these highly regulated properties of the endometrium need in the initial phase of pregnancy are possibly affected by uterine microbiota. Endometrial receptive analysis, we call this ERA, is a diagnostic tool to find the optimal time for embryo transfer and is recommended for patients undergoing assisted reproduction treatment. ERA offers the optimal patient's unique implantation windows as personalized embryo transfer. The team of Carl Simon studied on a genomic diagnostic tool for human endometrial receptive based on the transcriptal signature. They collect the endometrial sample from 88 healthy fertile women and 5 women with implantation failure or 2 hydrocephalus. There were 238 genes selected for the endometrium receptive assay to improve clinical implantation by personalized diagnosing and synchronize the endometrial factor. Previous published report the clinical utility of ERA. It guides a personalized embryo transfer by synchronizing the embryo with the implantation window to the patient in a personalized manner for the initial indication of implantation failure of endometrial origin. Now you can see that endometrial receptive ability was detected by the NGS method. They analyzed 248 genes expression and defined the status of the endometrium. A receptive result shows that the window of implantation is located on the day of taking the sample. The recommendation is to proceed with embryo transfer under the same condition as for biopsy. A non-receptive result shows a displaced window of implantation. In different cases, with the ERA computation predictor, windows of implantation will be estimated when patient's personalized embryo transfer is optimal. Simon reported a 5-year multi-center randomized controlled trial comparing personalized foreign and fresh breast cell transfer in IVF. They want to know, is there any difference in the clinical performance of personal embryo transfer guided by the ERA versus FET or ET in infertile patients under IVF? Participants were recruited from 16 reproductive clinics in Europe, America, and Asia, and randomized to one of the 3 arms indicated from November 25, 2013 to April 13, 2017. Infertile patients undergo IVF were recruited at their first appointment. We include women scheduled for embryo transfer at the breast cell stage, day 5 or day 6. Inclusion criteria were aged under 37 years, or BMI of 18.5 to 30, and the normal ovarian reserve. Like we see the antral follicle count over 8 and FSH under 8. Exclusion criteria were recurrent miscarriage more than twice, implantation failure more than 3 failed IVF cycles, and severe male fact infertility less than 2 million per cc. The table is reproductive outcome of the first embryo transfer. Clinical outcome of the first embryo showed pregnancy rate was significantly higher in the personal embryo transfer group, like we see 72.5%. Compared to FET, 54.37%, and ET, 58.8% groups. There were also significantly higher implantation rate and the lab birth rate in the personal ET than the FET or ET group. Not only implantation window, but also uterine microbiota affect embryo and the endometrial crosstalk. Fertility depends on receptive state of the endometrium, influenced by hormone and anatomical adaptation, as well as the immune system. Local and system immunity is greatly influenced by microbiota. Bacteria are known to affect immunity. If they already impact the immune environment of uterus before pregnancy, this would greatly impact the receptive potential of the endometrium, as well as the ability to correct initial placenta formation. Upon pattern reconciliation receptor stimulation, epithelial cells release soluble factors, such as cytokines, affecting local lymphocyte populations. If bacteria are naturally present in the uterus, similar interaction with host cells, as seen in mucosa of the gut, can be envisioned. Problems with the endometrial lining are one of the leading causes of infertility in women. A healthy endometrium is rich in healthy bacteria, the endometrium flora. Infections with harmful bacteria can cause disease of the endometrium, such as chronic endometritis. The endometrial flora or microbiome is the sum of the microorganisms and their collective genetic material present in the endometrium. And what is EMA test? EMA averages the endometrial flora to quantify all bacteria present in the endometrium, including the good ones. EMA also includes the ELISA test to identify the pathogenic bacteria most commonly associated with chronic endometritis. Following these results, Igenomix company recommend the best treatment to balance your endometrial flora, improving your pregnancy prospects. Lactobacillus is a major good bacteria in live birth. Granulosa was found miscarriage and no pregnancy group. We can see in this chart. And recurrent implantation failure, we call it IF, is a common imprecise-defined clinical disorder by failure to achieve pregnancy after repeat embryo transfers. Does the implantation window or microbiota change of endometrial function among women experience recurrent implantation failure? The purpose of this study was to evaluate the clinical usefulness of the endometrial testing and the PGS in patients with severe and moderate recurrent implantation failure. IF was defined as more than 3 failed fresh or frozen embryo transfer cycles. We analyzed the clinical outcome after IF women with optimal major good bacteria and personalized embryo transfer. Endometrial testing include ERA, EMA, and ELIS. ERA will enable women to perform a personalized embryo transfer, increasing the likelihood of successful implantation and a successful pregnancy. EMA will determine whether the uterine microbiome environment is optimal for embryo implantation. ELIS can detect the bacteria cause chronic endometritis or precipitate inflammation of the endometrial lining. This study was approved by the Institutional Review Board of Chongshan Medical University Hospital, Taichung, Taiwan. For a mock cycle pilot layer foreign Brussels transfer cycle that include an endometrial tissue biopsy for the implantation window prediction by endometrial receptivity analysis gene expression profile and microbiota analysis. There are 206 Endometrial testing cycle during November 2018 to May 2021. 62 cycles didn't transfer embryos because no euploid blastocyst. The exclude criteria were 51 non-IF cycles, including ovarian factor, male factor, endometrial disease, immune, multiple, and unexplained infertility factors. Totally, 93 cycles were transferred euploided or low mosaic blastocysts after endometrial testing. Trial involves testing the lining of the woman's uterus during a mock or pretend embryo transfer cycle. During this mock cycle, patients will prepare their uterine endometrial lining by taking progesterone. After 4 full days of taking progesterone, a small biopsy of patient's endometrium were taken to genetic testing the lining. Once the endometrium's genetic profile was determined, we would receive a report detailing the optimal time for patients to receive an embryo during a real transfer. The test result of ERA show receptive and non-receptive status. A non-receptive studies indicates that the endometrium is either pre or post-receptive. In this case, a new personalized window of implantation will be indicated. There were 3 patients showed different status of implantation window. The patient A was standard WOI. Her embryos transferred on P+5 or LH+7. The ERA result report a patient V with delayed WOI was detected pre-receptive status. The ERA report of patient C with advanced WOI was detected post-receptive status. Patient B and C need personalized either embryo transfer on the optimal time. Microbiota of endometrium was detected by Emma and Alice. The definition of normal endometrium microbiota was a percentage of lactobacillus in uterus more than 90%. According to their microbiota test, women treated with antibiotics and probiotics. They will transfer blastocysts on a suitable personalized implantation window. Emma and Alice report as the suitable. like the list table. Bacterial lists and antibiotics were recommended in different results. Patients performing endometrial testing prior to the FET in IF group were shown in Table 1. 93 IF cycles were included in this study. There were 60 IF cycles and 33 IF with oocyte recipient cycles. The average age was 38 to 43 years old. BNI was about 22. The duration of infertility was about 3.5 years. The previous IVF times were more than 3 times. Distribution of ERA results in IF infertile women was shown in this figure. The ratio of receptive states was 45. The percentage of pre- and early receptive implantation states of endometrium was about 30. The ratio of late and post-implantation status was about 25. Pregnancy rate from personalized ET after adjusting ERA in IF group was shown in Table 2. The pregnancy rate of receptive implantation states was lower than non-receptive implantation states, like 51.2% with 71.2% in total IF cycles. Pregnancy rate after adjusting ERA in both IF and oocyte recipient groups increased in non-receptive implantation states than receptive implantation status. Results of convention with pregnancy rate from personalized ET in different previous IVF times after adjust ERA in IF groups was shown in Table 3. The pregnancy rate of previous IVF 3 times was significantly higher than previous IVF more than 4 times in oocyte recipient groups. ERA would improve pregnancy rate if the endometrium was non-receptive implantation status. Distribution of the EMA result in IF infertile women was shown in Figure 2. The normal microbiota ratio in IF group was 50% to 37%. The abnormal microbiota percentage was 18 to 27. There was 23 to 49% endometrium cannot detect bacteria. The clinical outcome after antibiotics or probiotics treatment for different uterine microbiota states shown in Table 4. The pregnancy rate of normal microbiota in uterine was 66.6%. The pregnancy rate of abnormal microbiota group was 80%. The pregnancy rate was significantly higher in abnormal group than ultra-low group. Optimal microbiota status in uterine improved clinical outcome in IF patients. We also confirmed percentage of lactobacillus in pregnancy or not good after EMA. The lactobacillus percentage in normal, mild, and abnormal was significantly different either pregnancy or not. There were no difference of lactobacillus percentage between of normal, mild, and abnormal microbiota groups. Combine ERA and the EMA results. The pregnancy rate of non-receptive groups were involved from 51.2% to 73.3% in pre- and early status implantation windows, or 69.2% in post- and late status implantation groups. Receptive with ultra-low microbiota groups showed the lowest pregnancy rate. The means uterine still need optimal probiotics to improve pregnancy. Does the ERA really provide personalized embryo transfer? Performing the ERA test in a mock cycle prior to a FET does not seem to improve the ongoing pregnancy rate in good prognosis patients. 10 demonstrates that a significant proportion of patients with history of implantation failure of a euploid embryo have a displaced WOI as detected by the ERA. A 5-year multi-center randomized controlled trial of IVF with personalized breast transfer versus frozen or fresh transfer proved that pregnancy, implantation, and cumulative live birth rate significantly improved by personal ET. We suggest that ERA improve IF pregnancy rate patient in non-receptive implantation window. Reviews reported that ERA does not appear to be clinically useful for IF patients with PGTA treatment. Most oocyte recipients were advanced age group showed high non-receptive implantation states in our study. After treating antibiotics or probiotics for IF patients with abnormal microbiota, improved their pregnancy rate. The pregnancy rate of abnormal group was higher than ultra-low bacterial group, like we from 80% versus 46%. Personalized embryo transfer and optimal uterine microbiota improve clinical pregnancy rate in infertile women with recurrent implantation failure by Endometrial testing. Further large prospective studies are needed to educate the role of the ERA testing in patients with recurrent implantation failure. Thank you for your attention.
So thank you for Dr. Li. So Dr. Jia is have something emergency to handle, so she have to leave. So next time I will take over the motor to take the session. So okay, thank you again for Dr. Li. Yeah, RIF is indeed a very difficult problem in clinic work. Endometrial reproductive and intrauterine immune microenvironment are both an important consideration. Dr. Li's studies show us the clinical value of using the EndomeTRIO test to improve reproductive outcomes. Okay, so there are some questions to ask you. Okay.
Okay, sure.
So the first question is, what kind of the probiotics did you treat for your patients with dental products were lower than 19%?
Okay, in general, I would treat their bacteria. I usually offer the Urelax to patients whose lactobacillus were lower than 90%. Their microbiota of lactobacillus usually increase to optimal percentage after we use maybe 2 to 3 months, because maybe I think this will help the uterus environment. Yes.
Yeah. Okay, thank you. So there is another question. So what do you recommend for EMA result with your utero?
Oh, I think you mean the ultra low, yes?
Yes, ultra
Ultra
yes.
low, ultra low means uterus without any microbiota, or there or too small amount to detect in uterus. Maybe we cannot see any good bacteria in uterus. This is a very difficult situation because we always have this for the ET and the failed. I suggest to supply probiotics maybe to for those women for period. In my experience, if I met like this patient, I use the for 3 months maybe. Like we use the Urelax or others probiotics, yes, for 3 months for ultra low. That's my question. That's my answer.
So thank you. Okay. So the third question is, do you suggest all infertility patient or just a RIF patient to check Endometrial test?
Okay. Because the percentage endometrial testing, including like the receptive and the normal microbiota, maybe many patients have these results. And the other things is that I think the endometrial testing is a little expensive, okay, for some infertile couples. So if we want to do the endometrial testing, I suggest for the patients, we think the IF patients. Yeah, that's my answer.
Okay, thank you. Thank you. Last question is, if the patient has done ER test 3 months ago, then the implantation pre-receptive should be delayed implantation 1 day. Should her do ER test again before implantation?
This case I've met before. On the time I choose to send again the ERA and check again. But at that time I find a very unique things like the at first it's pre and then the post. So I talked about with the Igenomix and they answered me that maybe I should use the middle of this test. So if you have any question, I suggest you can send again and you can find the result. Yes.
Okay. Okay, thank you. Thank you. Thank you again for Dr. Li's answers and wonderful presentation. Thank you.
Thank you.